think this is an intimidating task for me today to try to talk to you blindly and not knowing who will be watching the video and not knowing everyone in the audience, because I'm going to speak broadly, and some of the things may seem totally superficial for people who have had Chiari for some time or who have multiple care. Sometimes may feel like I'm shooting over the top of everyone's head. So I also have no pride that if nothing makes sense, you're welcome to stop me and ask to recover something. But I'm just going to talk about briefly a little bit about what Chiari malformation is and what we do as surgeons to treat that. And to start off, I want to talk about how I dislike the word Chiari malformation to begin with. It's kind of a scary sounding word. One, it has malformation in the name, and no one likes to be told that their brain has a malformation in it. And in reality, I think a better term would be if we called it the Chiari variation, because more often than not, this tonsils, this bottom part of the brain that sits right here at the big window that lets the spinal cord and come in out of the brain, is a variation on normal. We know from doing scans, well, they will do a prospective study on hundreds of people who have no neurological problems, no headaches, and they'll do MRI scans on those people. And they'll see about 1% of the time bits of the tonsil sticking down below the base of the skull. And those are people who aren't having headaches, who aren't having problems with their arms and legs, whose spinal cord is totally fine. And they have this entity, and so they don't need surgery, and we'd be doing an injustice to do surgery on them. In fact, they'll never even need a head doctor. But there's also a whole group of people who have terrible headaches, who have terrible problems with their spine, and the difficult thing is telling the difference between those two groups. So I don't like to say malformation, I like to say variation, and Chiari is also just a scary sounding word, and I wish we'd have come up with another term. So tonsillar ectopia ectopia is a word that just means something's in the wrong spot, and the tonsils are this little bit of tissue that hangs down from the back of the brain. That's a better term in that it is a little less judgy sounding, and it just means that the tissue is in a slightly abnormal spot, but there's not necessarily something incredibly wrong with it. But about 3 million people have this tonsillar ectopia if you figure 1% of the population in the United States, and the vast majority of them will never need treated or never need any surgery. So Chiari does not necessarily equal a headache, or tonsillar ectopia doesn't necessarily equal a headache or a disease, and it doesn't always need surgery, but boy, it certainly does for some people. So who are the people who need manipulation? Who are people who will get better with surgery? So I think one of the hardest things in my job is the actual decision to do surgery or not to do surgery, and what type of surgery to do. That an incredible amount of my training is of how I actually physically manipulate tissue, and sometimes that's the thing I'm most comfortable in. But to actually look someone who's come to my office for help, who's suffering terribly, to say, yes, the best thing that we can do is make an incision in the back of your neck and drill a portion of your skull away. That's a decision that I take very, very seriously, because if we choose wrong, usually there's not a great deal of complication, but it means no one gets any better, but they've paid a great deal price and their time and their discomfort to go forward with the surgery. And if I can't go forward with an incredible chance of making them better, I certainly don't want to put them through the risk for it. And if you have headaches are a very common thing. I treat mainly children, so most of the things I'll talk about here is numbers related to children, but most of these numbers are pretty similar across adults and children. And about 10% of children have frequent headaches, more than once a month, often more than once a week. And if we do a scan on people who don't have any headaches or any head problems, we see abnormalities about 25% of the time. Those are often little things that are small cysts in the glands or changes in the way the fluid surrounds and coats the brain. But the example I always like to use is moles on people's faces. Some moles are deadly. Some moles are going to totally alter your life and kill you, but they usually aren't. They're usually small deviations on normal, but we're used to looking at faces all day long, and so we see small deviations from normal and say, okay, that's a healthy thing. We're not used to looking at the inside of people's brains, and now that we have the capacity to look inside of people's brains, almost everyone who's had chronic headaches week after week, month after month will get an MRI scan. But we know even if they didn't have any headaches, we would see about 25% of the time something that looks somewhat abnormal. And so we have to always ask ourselves, is this just a normal healthy mole, something that we would see on a face without a disease, or is this something that's aggressive, something that is causing your problem and we have to intervene on? And that's a very difficult process in the decision making. There's examples of things that are clear signs to me that we need to do an intervention. And one of them is this term that we keep saying over and over, Syringomyelia or syrinx, which is a fancy way of saying a bubble that's being blown up within the spinal cord. The word syrinx comes from the same Latin or Greek root like syringe, the fluid-filled tube that we inject fluid with in the hospital. There's a clear fluid that's made in the brain called cerebrospinal fluid, and it trickles down through the base of the brain and then surrounds and coats the brain and the spinal cord. There's a healthy small tube that's about a 1/16 of an inch wide that comes down through the middle of the spinal cord. But for some reason, in some people with syrinx, when it's pinched in that area, it causes fluid to build up within the spinal cord. And if that goes untreated, that can make people paralyzed. It can make them lose their strength in their arms and legs and have all sorts of terrible complications. In some ways, that's easy for me as a doctor when I see that, because I can say, this is a pathology, this is a patient who we should intervene on, and we don't have to debate it. There's also some classic signs that pain at the back of the neck, particularly with headaches, with sneezing, with bearing down, such as lifting a heavy weight, having a bowel movement. That's a more convincing sign that we should do surgery on that patient. There's also some things related to how the base of the skull here meets up with the spine. We call them craniocervical instabilities. And for some people, the way that they grew when they were in their mother's belly, the joints and the bones did not fuse themselves together in a way that's strong enough. And so movement with their head from side to side or forward and backwards, rather than the normal movement that we have, can rock too forwards and backwards. And for some people, they even have to have bony fusions to prevent their head from moving too far to damage their spinal cord. So these are some general guidelines that I think about of who needs surgery. But again, it goes back to that if you've seen one Chiari patient, you've seen one Chiari patient. And I never like to be too specific about who exactly and who doesn't need surgery. I like to make a decision based on the best evidence we have, but also on each individual patient's story and experience. So what do we do when we talk about this surgery? And Tonda mentioned it a little bit earlier about this big study that's just being completed about will we just drill bone or will we sew in a patch? I want to talk about that in a little bit more detail. So the simplest version of the story is called an extradural decompression, and that we remove this pinching at the base of the head by drilling away a portion of the bone. So we're looking at someone's skull from the back side. So this is their right side, this is their left side, this is the back of the head, these are the bones at the top of the neck. The simplest version is we use a small drill after everyone's completely asleep and drill away a rim of bone at the base of the skull. So it's not pinching where these tonsils are coming out. We drill away a little bit of bone here, and there's a coating over the outside of the brain. It's not actually it's not actually part of the brain, but it's like a sac that holds the fluid around the brain. We call that the dura. We can stretch that out a bit by making teeny tiny score marks to be able to allow that to stretch and pull and make more room for the CSF to travel around the base of the brain. The advantage of this surgery is that it's a faster surgery and it's less irritating to the brain and less difficult to recover from, but we can't make quite as much space for CSF to flow around the base of the brain. A more aggressive version of this surgery is what we call a duroplasty. So the first part of the surgery is done exactly the same as where we just drill off bone or just remove portion of the back part of the spine there. But the duroplasty means we make an incision and we sew in a patch. So we take the tissue and sew in a patch so there's even more space sitting around the bottom part of the brain and around the spinal cord, to allow more space for CSF to flow back and forth in this area so it doesn't get pinched, so there's reduced pinching of the top of the spinal cord and the bottom of the cerebellum. The disadvantage of this is that it's more irritating to the brain. I never see the brain here. The brain's kept protected in its happy sac. No bits of blood get around it that can irritate the brain. There's not air that gets inside of the brain, and it's a shorter surgery. For here, there's always a few drips of blood that travel into this space that actually is irritating to the brain. It feels almost like an infection to have that blood. And people are often more nauseous afterwards. They have more soreness afterwards. And also, we work very, very hard to sew this patch in watertight, but occasionally fluid will start to leak out through the patch, and that can increase the chance of having a complication from the wound, having a new type of headache called an overdrainage headache, that you get a different symptoms of headache. It's maybe novel to have a slightly better different headache, but you're not really thankful for us to just trade it for another headache, and potentially have to have more surgery. The advantage of it is that it can give us much more space for CSF to flow, but at the cost of more risk for the surgery and more time for the surgery. And so we try to be very judicious about who do we add extra manipulation, extra surgery to, if we can get away with a less painful, shorter period of time in the hospital. So our goals of the surgery are to take away this pinch here at the back of the brain, and that's potentially done just by drilling off this bone in this area here, or by sewing in a sac so the leather, over the back of the brain is wider and bigger. Yeah, go ahead.
What are you using for the patch?
So that's a great question. So there's a lot of debate about what people should do for the patch. My preferred method is to use a pericranium patch, which means we use your own tissue is the idea. We make a separate small incision further up on your scalp. There's a coating over the outside of the skull called the pericranium. It's almost, again, like a thin leather. It's nice and strong and watertight. And we cut away that thin coating. It's not your skin, it's underneath your skin. So we're not cutting a patch of your scalp completely off and sewing it again in your brain. It's just an inner layer. We harvest that from a separate incision and then sew that in around the opening. There's also some synthetic materials that people like to use, things called Alloderm, Duragen, Durarepair, that are made from either harvesting cadaveric skin, so the cells are removed, but the protein, the collagen's left behind, the sort of the hard stuff that keeps it together, or things from, I think it's most typically harvested from cattle, of using that same sort of collagen inlay. The advantage of that is you don't have to make a separate incision that also has to heal, but there's certainly some case reports of people who feel like they have an immune reaction to having that put in case. I've used it for lots of surgeries, and I've used it when I've had to do a redo surgery where I used the pericranium the first time and the patient didn't get better and I had to go back and add something in. And typically my experience for most of the time is that people have a very good experience with it. Psychologically, it's tough to know that something else has been sewn into your body, so I don't like to add it if I don't have to. That risk, we haven't really established it in like a randomized trial where we randomized 100 people to have their own patch or 100 people to have this synthetic patch. But I feel like I can get good tissue without a lot of risk for people, so I like to use their own tissue, at least for the first patch if I have to do it. I see you had a question. Yeah.
I have the bovine Dura patch.
Yeah.
I was curious if that can cause problems later on.
So that it goes back to that same thing, that for the most people who have those patches, they seem to never go on to have a problem, but it certainly seems like there's a population of people who are particularly frustrated with them, and I wish I had great science to know that absolutely it happens. There's certainly people who are frustrated with who have a pericranium patch put in place as well, so I wouldn't necessarily go in and take it out just because you're having difficulties. There are some patients who have them who profoundly believe that because it's that synthetic material, it's the cause for some of their symptoms. I don't have good evidence to guide me in one direction or the other, but if I have tissue that I can avoid it, I just try to avoid it. But I've used it on dozens and dozens of people who don't have a problem, so I know it's certainly safe for some people, but I don't think I could ever be so bold as to say, I know it's not your problem, I know that it couldn't possibly be from your bovine patch. I don't want to seem conspiratorial. I just don't want to also dismiss anyone's symptoms and say that I know that it's not the case because I don't have the science to be able to say it. Does that make sense?
Yeah, absolutely.
So goals of the surgery. Again, the goals of the surgery depend a little bit on what your symptoms are, but from a surgery standpoint, my goal is to make sure CSF is flowing through that area. And then what we declare as victory depends on a bit what your problem was to begin with. This pain at the back of the neck is our most common reason to have to do surgery, and so our goal is to reduce that pain. But also, if you're one of these patients who have fluid built up within the spinal cord, we want to make sure that that fluid at least stays the same size or starts to sink down. We want to improve strength and sensation if patients are having problems with weakness or sensation because of it. And there's a certain number of patients that the nerves that travel off to the neck to help you swallow or to control your breathing when you're asleep at night can also be compressed by the Chiari malformation. So we're particularly interested in assessing is patients having problems with those symptoms before the surgery, and also are they improving. But above all, our goal is to return the people to their lives before they had these symptoms, or if they've had these symptoms, return them to a life that they didn't have before. And that's what I like to emphasize, that I don't want to say that there's one particular goal for all patients. The simple answer is I want to make the fluid flow well around your brain. I want to get you to a life that's better than the life that you're having. And the goals in between depend on what your problem was to begin with. It takes a lot of people to take care of these patients, and I've certainly been called obsessive before, but I have to rely on other people to help me. Partly because I can't put you to sleep and wake you back up myself and do the surgery. So we have an anesthesiologist who sends patients to sleep and wakes them back up. But also you need a lot of care when you're in the hospital, that you're very stiff and sore after the surgery, and so there's a bedside nurse who's helping you with your pain medications, helping patients to get around, to help them walk around and to get their feet back underneath them. We have physical therapists helping with that. And for patients who we do the surgery where we sew in a patch around the base of the brain, I put them in the ICU for at least one night afterwards, which means there's another set of doctors, the ICU doctors, helping to take care of us. Because we're trained as neurosurgeons on adults and children, then most of my practice is on children. I still like to have a pediatrician involved in making sure that there's something that I'm not missing about the care of a child. So all of the patients who admit for this surgery, I have a hospitalist pediatrician also seeing them, helping to guide me on their care. And we have resident and fellow doctors who are people who have either residents have finished medical school and are in their final training to be able to practice independently, or fellows, people who have done all of their training but are coming back for some very specialized training to perhaps do this type of surgery or operate on children in particular, who assist us. They're my third and fourth hand in the operating room, or they're the person who can see you at 6 o'clock in the morning or come to the bedside at 2 o'clock in the morning, because I can leverage my extent. If I had to do that all the time, I would take care of maybe 1/10 of the children who I can in a year. Because I have this additional help, we can take care of a bigger number of patients. But I still see every patient every day, and in the end I put my name at the top of the list, because even though someone may be at the bedside when I'm not there, in the end I'm the person who's responsible for the care that you receive and for the outcome that you have, and I'm responsible for any of the decisions or care that any of these people give during your stay in the hospital. But I mean it that it's a team, and that we can't accomplish these things on their own, and it takes all these groups coming together. Someone has to be the coach of that team, but everyone has to be on it. And what's the recovery from surgery? Because patients are really variable, because this disease is really variable, I also am really broad when I talk about what's recovery from the surgery, and what does that even mean? Does that mean how long are you in the hospital? How long until you start to feel better? How long until your scar goes away? All those things are really different. The typical stay in the hospital is from about 2 to 7 nights. Patients who have only the bone-only surgery go home faster. I've even seen patients begging me to go home after one night in the hospital, but I get paranoid and typically don't let them go. The more average stays between them do about this 2 to 7 nights, and the return to school or to work is also variable. From about 2 weeks to 6 weeks is the time that most patients have away, and I'm really cautious about sending people back to school or work. You look like yourself if you have long hair, your scar is covered up, and when you go back to work everyone expects that you're you, but you've just been through brain surgery. So it doesn't necessarily break people's brains to go back to work early, but they can become more easily fatigued. Their concentration can still be a little off. And if I send kids back to school too quickly, then suddenly their teachers may think that they're them and want to have them pass tests, and their grades can be affected because they come back so quickly. So I try to always make sure they go back with a note that says, please excuse Sally or Jimmy early from school because they've just been through brain surgery. And usually that kind of phrasing at least gets them out of a test or two or a gym class. I like to have patients up and walking by postoperative day 1, or at least up out of the bed, wiggling your toes. Our bodies are made to move, and if I would take anybody and force them to lay in their bed for too long, that would make you feel sick and feel sore. And so I'm also worried about making sure that you don't get a sickness in the hospital because you're just in the hospital. So I want people up, moving around, moving their legs so they don't get blood clots, so their lungs are opening up to prevent the chance of getting a pneumonia. I don't want them miserable, but I want to slowly encourage them to get up and move. And that's part of that team of we have the physical therapists and occupational therapists who are also getting patients up to help them to walk around and to encourage them to move. So the things that bother people most after the surgery is people aren't in excruciating pain. They're not writhing around, unable to talk or to interact. But they have the stiffest neck that they've probably ever had, and I describe it to people, and as patients have described it to me, as sort of the worst neck you've ever woke up with sleeping badly at a night, that the whole neck hurts and is sore, and that's because we had to take those muscles and pull to either side for several hours to operate. So I inject lots of numbing medication at the end of the surgery to help with that, but the numbing medication doesn't last for days, only a few hours. We give lots of medications both for muscle spasm and pain medication and in general, but people often are bothered most by moving their head side to side for the first few days after the surgery. And that slowly calms down over a few days or a few weeks before they really feel themselves again. Nauseousness because you've had to go through sedation, and particularly if we had to do the duroplasty, opening up over the back of the spine and the brainstem there is over the top of one of the areas that they call the emesis center, which is the part of the brain that senses strange chemicals and makes you feel you need to vomit, a thing that sits right at the opening where we're working. So in order to free up the scar tissue often and make CSF flow, I literally have to manipulate that with the instruments, which means that patients will feel really nauseous afterwards. So I have my anesthesiologist start giving the anti-nausea medication even before we take the breathing tube out to try to limit how nauseous people are. Constipation, it's of course taboo to talk about people's poo in public, but I also like to talk about it beforehand because we don't want people to have to bear down when they're recovering from the surgery. That bearing down is often the thing that makes people have the most pain. It's one of their symptoms that they present with, and bearing down, if we have to sew that patch in, can actually push the fluid out of the patch. Plus, often people need a lot of pain medication. The first thing pain medication does is it makes you constipated, and then it sometimes helps with your pain surgery. So we are very mindful of making sure that people are going to the bathroom well. And people just have low energy. I kind of have had patients describe it to me that they feel like they have the flu. Not that they're achy or fevery, but it's just that same sort of, I'm awake, I'm myself, but boy, I don't want to feel like doing anything. And that's the first few days after the surgery. I don't let anyone go home until they're taking medication by mouth that's controlling their pain. So I'm happy to keep people there to give them all the assistance for pain medication that they need, but I need you to have to be on a regimen that you can reproduce when you're at home. I need people eating, drinking well, walking, and able to get themselves to the bathroom, and that depends on what their home life is. For adults, some adults don't have anyone that lives with them, and we keep you in the hospital a few days longer because you need to be recovered to a couple steps further before you can get yourself to the bathroom and back and the kitchen and back with only friends or family coming in every so often. For children, I can sometimes go a little bit earlier because either they're small enough a mom can pick them up and move them around, or they have parents who are there 24 hours. But I always like to make certain that no one feels like they've been kicked out of the hospital and no one feels like they're in St. Louis Children's Jail, that we have to strike a balance between not keeping anyone feel like they need to be there longer, that they don't feel safe taking care of themselves, but also not feeling like they've been forced to stay in a place that they don't want to be. And then the follow-up after the surgery, I always see someone after the surgery about 2 weeks afterwards to check on their wound, to make sure that it's healing well, no signs of an infection, that their pain has been well controlled after they've gone home. And for when we use sutures that aren't absorbable, this is when we take them out, but I've moved to using almost always a reabsorbable suture. It reabsorbs on the inside of the skin and it starts to fall out on the backside. It starts to fall out usually between 2 weeks and 2 months after the surgery, but it's really variable, but at least spares me having to take 7-year-olds and convince them that it's going to be okay if I cut sutures on the back of their neck. I'm not cutting them, but boy, they do not like to see the doctor with a pair of scissors, so we try to avoid that. The follow-up, again, depends a little bit on their symptoms, but we usually will see people again about 6 to 12 weeks after the surgery to make sure symptoms are still improving. For people with very large syrinxes, that fluid space in the spinal cord, that's when I often repeat the MRI scan to make certain that the syrinx, that fluid space is getting smaller or getting better. And people are sort of stuck seeing me for a period of time, though, and I don't mean to say stuck, but I never just want to declare victory after we do the surgery. And if you talk to people who have Chiari malformations, as many of you in here have, that their symptoms can get better for a short period of time or for a very long period of time, but symptoms start to come back. And I like to maintain a relationship for people of one, it can sometimes help with the fear that the symptoms are coming back, of knowing I've got a date in my calendar that I'm going to see the surgeon again to be able to talk about these symptoms. And two, I don't want people to feel that they're unwelcome to come back and talk about the symptoms. And I want to catch it early when symptoms are reoccurring to see if we should have to do one of these repeat surgeries. I hate having to do it, but I think any surgeon would be lying if they said they've never had to do a repeat surgery, because that's the disease process. And anyone who claims that they have no complications with this surgery, I would probably not have my surgery with them, because I don't think they're a trustworthy person if they're saying they have no complications. And that's the general process. And I follow children until they are too old to be able to be seen at the Children's Hospital anymore. And that's usually either through their 18th or 25th birthday, depending on when we started seeing them. Anyway, thank you very much.